first speaker was Dr. Jose Ramon Gonzalez Juanatey. He is from Spain. He will talk on heart failure, unmet challenges, and emerging therapies. Dr. Jose Ramon Gonzalez is the past president of Spanish Society of Cardiology. He is the director of cardiovascular department, University Hospital, Santiago de Compostela, and professor of cardiology, University of Santiago de Compostela, School of Medicine. He is the member of ESC Education Committee and member of number of task forces for a number of Esc Guidelines. He is the member of editorial board of European Heart Journal, Lancet, Circulation, American Heart Journal, Revista Española de Cardiología. His topics of interest is heart failure with preserved ejection fraction, hypertension, acute coronary syndrome, and cardiac myocyte endocrinology. He has got more than 500 publications in the most prestigious journals in the world in the field of cardiovascular medicine. Dr. Jose Ramon Gonzalez, please.
Thank you. Thanks for the introduction, and thanks for the invitation to participate in this international summit. My topic is heart failure, and as probably you know, last weekend was presented in advance antevision of the new ESC guidelines that will be published in the full paper and presented in the next ESC Congress at the end of the next August. I will address the issue of the emerging therapies, some of the new aspects that probably could be included in the new ESC guidelines. On this slide, my disclosures. And first, I would like to address the diagnostic challenges in heart failure. And recently was published the first universal consensus, the universal definition of heart failure. This is a joint paper for the ESC, the American Heart, the American College of Cardiology, and the Japanese Cardiac Society. And this is the new classification proposed, and is the new classification that is included in the next ESC guidelines. Heart failure will reduce ejection fraction, defined by an ejection fraction lower than 40%. The new category, that is the new definition of the new, in the past, in the previous guidelines, we define as mid-range, and now is defined as mildly reduced ejection fraction, an ejection fraction between 41 and 49, preserved ejection fraction higher than 50 and equal than 50, and a new category that is, for me, very, very important, this new category that is included in the classification of heart failure, that is heart failure with improved ejection fraction. And here in the slide, you can see the definition of the improved ejection fraction in patients with depressed that increase the ejection fraction. And this is so important because in the new ESC guidelines, ejection fraction will be considered as a therapeutic target because the patients with an improvement in ejection fraction, the prognostic is much better than patients who remain with depressed ejection fraction. So the aim in the clinical practice in patients with depressed ejection fraction is increase the ejection fraction by means of the background therapy, the prognostic implications, the therapy with prognostic implications, revascularization, cardiac resynchronization of all the interventions that may increase the ejection fraction in heart failure. So this is the proposal that HFrEF, if the patient improves the heart failure, is like in cancer, it's like a remission of the heart failure syndrome. The patient needs to maintain the treatment, but the prognostic improves a lot. The prognostic is much better in the patients with the remission, with this improvement in ejection fraction and the reduction in the cardiac volumes. This is one of the news that should be included in the new ESC guidelines, ejection fraction as a therapeutic target. And HFpEF, this is the proposed algorithm for the HFpEF diagnosis. In clinical practice, HFpEF It's a clinical syndrome of heart failure, and then the use of natriuretic peptides, echocardiography and echo and Doppler and the E prime cutoff points. So this is the proposed clinical algorithm for the diagnosis of HFpEF. I think this is critically, we have to get in considerations the clinical elements that should be included when you establish the diagnosis of HFpEF. It's a clinical score system that was previously published in a position paper of the ESC, and this is the algorithm that should be included in the next ESC guidelines. And what about the therapeutic challenges? In the ESC guidelines, it is what is new in medical treatment in ESC heart failure guidelines, a new algorithm, the new recommendations for mildly reduced in the past mid-range and now mildly reduced, a new classification, characterization of patients with heart failure based on ECG, the etiologies, and other clinical parameters. So what is new in the ESC? And this is the new algorithm, treatment algorithm for the management of heart failure with reduced ejection fraction. This is an algorithm with four class of drugs with a demonstrated improved mortality risk and a demonstrated improvement in the reduction in the need of heart failure hospitalization. ACE inhibitors or ARNI, sacubitril valsartan, as class 1, but the guidelines probably will say that ARNI is preferred, but include also ACE inhibitor as a possibility. And in patients with previously treated with ACE on RRB, then ARNI should be included, should substitute ACE or NRB, beta blockers, anti-ALDO, and SGLT2 inhibitors. This is the four groups of drugs that should be included unless contraindicated or unless not tolerated by the patients. Diuretics only in patients with volume overload, only in the presence of congestion, not for all the patients, only in this clinical situation. RRBs should be used only in cases of patients with intolerance to ACE or ARNI. Carboxymaltose intravenous iron in patients with iron deficiency. This is 2A. Digoxin was increased the level of evidence. This is 2A in patients with that needs digoxin for rate control in patients with atrial fibrillation, ivabradine and hydralazine and dinitrated isosorbide. But the four bigs, the four class of the patients. And in the table, ACE is recommended for patients with HFrEF, that you see is a class 1 level of evidence A. Then sacubitril valsartan is recommended as a replacement for ACE in patients with HFrEF with the aim of reducing the HFrEF or heart failure hospitalization and death. So sacubitril valsartan may be the first option in patients with HFrEF, or substitute ACE inhibitors in patients with stable HFrEF in the ambulatory basis. The issue is the evidence that we get support that ARNI should be included as first line instead of ACE inhibitors of RRB. We have a clinical trial that is the Pioneer HF, and in naive patients, in patients without a previous treatment with ACE on RRBs, that is half of the patients included in Pioneer, the reduction in NT-proBNP compared with enalapril was significantly higher, and the events was significantly less. But the trial was not designed to test the hard endpoint. So with this evidence is sufficient to delete ACE inhibitors from the first line of treatment in patients with heart failure. Probably all of you will have your position, but I think that is not a relevant issue. ARNI is significantly better than ACE inhibitor, but if you start for many reasons, maybe for economic reasons due to the price of sacubitril valsartan, but in the case that you start with ACE, then you have to consider the change of ARNI in such patients. And one of the new is the inclusion as class 1 level of evidence A of the SGLT2 inhibitors, particularly dapagliflozin and empagliflozin, based on the DAPHF clinical trial in diabetic and non-diabetic patients with HRF. Dapagliflozin much improved the prognostic of the patient, reduced the risk of the composite endpoint of cardiovascular death or worsening heart failure, and the same findings in EMPERO reduced. Empagliflozin reduce the risk of suffering the components of the primary endpoint, that is worsening heart failure and cardiovascular mortality. These are the two big trials in HFrEF this is the reason why the new ESC guidelines and the American guidelines, the Canadian guidelines include SGLT2 inhibitors as class 1 level of evidence A in all the patients with HFrEF, irrespective to the diabetic conditions. And at the end, in HFrEF, you have to include ACE, ARNI, probably preferred ARNI, beta blocker, anti-ALDO, and SGLT2 inhibitor. The mechanism of the FARB drugs are independent and additive, and the benefits regarding the improving the prognostic are incremental. So the goal is include all the 4 drugs, the earlier the better, with this aim. And probably, and this is one of the recommendations of the ESC guidelines, you have to discharge the patient from the hospital with all the 4 drugs, and then up-titrate the dose. But some of all of the 4 drugs, unless not tolerated by the patient. This is the American algorithm. Here is stated that ARNI is preferred, and then beta blockers, and then SGLT2 inhibitors of anti-aldosterone antagonists and aldosterone antagonists, considering the kidney function and the potassium, and in this case also the kidney function. It's more or less the same algorithm. This is the Canadian algorithm that is almost the same algorithm that the new European algorithm, and you see that is ARNI or ACE or RRB, and then substitute by ARNI. Is the same philosophy that the ESC guidelines or the ESC new algorithm, beta blocker, anti-ALDO, and SGLT2 inhibitor. And this is the 2 years mortality with none of the 4 drugs. The 2 years mortality is higher than 30%, and with the optimized medical treatment in patients with HRF, the annual mortality is less than 5%. This is really it's an impressive improvement in the prognostic, and this is the reason why you have to try to include the 4 drugs in the treatment algorithm of your HRF patients, because the prognostic impact and the improvement in the quality of life is much significant. But at the end, you have to consider several clinical issues: the heart rate level, the blood pressure, atrial fibrillation and non-atrial fibrillation, chronic kidney disease, because you have to individualize. And this is much important in heart failure. You have the need for individualized the treatment. for example, in the future will be included in the armamentarium of heart failure. We reduce ejection fraction vericiguat based on the Victoria trial results that vericiguat improved the prognostic in heart failure in patients with advanced heart failure, patients with repeated readmissions to the hospital. What about the role of the priority patients for the use of vericiguat? Here, the iron, intravenous iron, in this case, the affirm acute heart failure in patients with iron deficiency, an improvement particularly seen in reducing the risk of hospitalizations, non in the reduction of cardiovascular death. This is the reason why in the new ESC algorithm, this is a class 2A recommendation, and you have to identify patients in clinical practice with heart failure and iron deficiency. And again, a sub-analysis of the Cabana trial, the role of cardiac ablation in atrial fibrillation, venous vein pulmonary ablation, and this is the improvement in the prognostic in the subgroup analysis. This is a subgroup analysis with all the limitations, and improvement in the prognostic based on the atrial fibrillation ablation in patients with heart failure. So you have to select heart failure patients with recent atrial fibrillation for considering ablation. And a new chapter is patients with heart failure and cancer. You have to develop areas of cardio-oncology in the hospitals. You have to identify the cardiotoxicity, particularly in women with breast cancer, because you use, in this case, ACE inhibitors and beta blockers for the reduction, the risk of cardiotoxicity, and particularly the reduction, the risk of suffering chronic heart failure. So it's needed to develop in clinical practice areas of cardio-oncology for optimize the risk, cardiac risk in oncology patients. This is the results of our paper recently published in the European Heart Journal. You have to identify and treat early the possible cardiotoxicity because the patients, particularly women with breast cancer with cardiotoxicity, the prognostic is worse regarding the other group of patients. You have to identify the cardiotoxicity and treat the patient with the aim of avoiding the development of overt and chronic heart failure. And at the end, HFmEF, in this case, HF failure with mildly reduced ejection fraction and HFmEF. This is the table. This is a crazy table in my point of view, because all the drugs is 2B and level of evidence C. This is saying nothing, almost nothing in heart failure with mildly reduced, heart failure with an ejection fraction. And 49, you have to individualize the treatment based on the phenotypic, on the clinical characteristic of the patients. This, from my perspective, this is a crazy table. Does not add nothing relevant from a clinical point of view. The possible role of sacubitril valsartan in patients with an ejection fraction lower than 57, 55. This is many patients in the mildly reduced ejection fraction based on the Paragon sub-analysis, and this is the reason why it was accepted as a possible indication by the FDA. And recently was published a press release regarding the results of the Emperor Preserve. Emperor Preserve is a clinical trial in heart failure patients with an ejection fraction higher than 40, so includes patients with heart failure with mildly reduced and preserved ejection fraction. The press release said that the empagliflozin improved the prognostic of these patients for the first time, a clinical trial improving the prognostic, but we have to wait to see the full paper in New England Journal of Medicine and at the end of August, and also will be presented in the ESC. This is probably a new era in HFpEF, in HF failure with mildly reduced, but with preserved ejection fraction, but we have to wait. And we send, because I am in the steering committee of the trial, we sent the paper for considering for publication in New England this week. And at the end, the patient care pathway, this is critical. This is the new recommendation of the Esc Guidelines. The patients should be discharged from the hospital with some of the 4 drugs improving the prognostic: ACE, ARNI, ACE of ARNI, beta blockers, anti-ALDO, and SGLT2. And then the patient should be followed, a health contact in 1-2 weeks after hospital discharge. For me, this patient care pathway organization is critical in the organization of patients with heart failure. And then this is the patient pathway during the hospital stay. And then this is in the transition to oral therapies. At the beginning, due to the congestion, low cardiac output, the patient needs many patients intravenous medication. And in the transition to oral therapies, these big 4, with this objective, the earlier the better, and discharge the patient from the hospital with some of the 4 drugs. You have to take into consideration that the tolerance of the neurohumoral blockade, the RAS inhibition, the renal function, the potassium, the hypotension. And during the hospital stay, because the patient is well controlled, probably you can start with beta blocker and ARNI, and then include anti-ALDO and SGLT2 inhibitor. This could be maybe a strategy. SGLT2 inhibitor is one dose, one step, but the other drugs is 1 of 2 doses and several steps for achieving the target dose. And recently it was published that if the patient with heart failure is already treated with an SGLT2 inhibitor, in this case empagliflozin, the risk of suffering side effects under anti-aldosterone with aldosterone inhibitors, antagonists, is much less. So this is the reason why Milton Packer and John Murray propose that you can start with beta blocker and SGLT2 inhibitor, and then include an ARNI, an anti-ALDO, probably due to the beta tolerance of ARNI and anti-ALDO, less risk of suffering, particularly hyperkalemia. Otherwise, you have to design an individualized strategy in your patients with HRF. Not all the patients with HRF are made equally, so you have to adjust your strategy, but the aim is to include all the 4 drugs in the treatment strategy after hospital discharge, and then plan the follow-up for increasing the dose. And this is my final slide. This is the Esc guidelines probably, and we can discuss, include recommendations for device therapies, ICD, CRT, mitral clip, revascularization after the ischemia trial, and the results in the ischemia trial in patients with cardiac dysfunction, the diagnostic and the treatment in acute heart failure, the role of amyloidosis, and the COVID-19, and the role of COVID-19 in suffering heart failure and in patients with previously heart failure. So this is my view of the emerging therapies and my view of the news, what's new in the new ESC heart failure guidelines. Thank you. And then if you have any comment of any questions, I will be more than happy to comment. Thanks. Hello? I can hear you.
Please unmute yourself.
Yeah.
Okay, thank you. Thank you, Jose Ramon, for your brilliant presentation. It is really an updated presentation on heart failure. We can take very few questions. I think there are a lot of questions. Among the chairpersons and discussant, have you got any comments and questions? I can see Shazal Banerjee, sir.
Yes.
Sir, have you got any question or comments?
This is an exceptional presentation by Gonzalez. I must congratulate him. And I also congratulate Dr. Anil Saxena for his nice presentation. I have a question to Gonzalez. Is there any recommendation of any drug to prevent heart failure right now? Is there any preventive drug?
Yeah, it depends. It depends of the type of patients. For example, in patients with ischemic heart disease, in patients with normal left ventricular ejection fraction, probably ACE inhibitors prevent heart failure. So, probably beta blockers, the combination of beta blockers and particularly ACE inhibitors prevent heart failure in ischemic patients. In diabetic patients with normal ejection fraction and without heart failure, SGLT2 clearly prevent heart failure. So in our ischemic patients, SGLT2 inhibitors, particularly ischemic patients with diabetes, the SGLT2 inhibitors prevent heart failure. Recently was published a subgroup analysis in the ischemia trial that patients without the clinical syndrome of heart failure but with depressed ejection fraction, an ejection fraction between 40 and 50%, the revascularization in the case of suitable anatomy reduce the risk of suffering heart failure. So at the end, you have to consider the type of patient. For example, in hypertensive patients, the blood pressure control much reduce the risk of suffering heart failure. But I think that the newest evidence suggests that the blockade of the RAS system in ischemic patients prevent heart failure, and SGLT2 inhibitors in diabetic patients prevent heart failure.
Thank you, sir.
Thank you. Very recently, there is a report that SGLT2 inhibitor is a preventive drug irrespective of risk factor. Do you agree?
But SGLT2 inhibitor is a preventing drug in the cardiorenal syndrome. Not only protect the heart, prevent the heart failure development, but also prevent the kidney dysfunction. At the end, is a kind of blockade of the cardiorenal syndrome. But this demonstration only was seen in diabetic patients. In non-diabetic patients, based on the result of the DAPA-CKD, was seen in patients with chronic kidney dysfunction, irrespective to the diabetic or non-diabetic. In this case, patients with chronic kidney dysfunction, dapagliflozin in DAPA-CKD prevent the cardiovascular complications and prevent also heart failure. But SGLT2 inhibitors mainly prevent heart failure in diabetic patients, and now after the DAPA-CKD, also in non-diabetic patients with chronic kidney disease.
Thank you, sir. Thank you. Dr. Jose Ramon, do you recommend continuing all these 4 drugs in patients with heart failure with recovered ejection fraction?
That is a very interesting question. But as I mentioned before, the new heart failure classification includes this new category of recovering heart failure, improving in left ventricular ejection fraction. This is critical because this subgroup of patients with an improvement in ejection fraction, the prognostic is much better. But you have to, the recommendation is continuing the same medication. Probably because this is like in the cancer, this is the remission of the heart failure syndrome, but at the end, the cardiovascular and the cardiac damage remain. And 2 years ago, I think was published in Lancet that in patients with heart failure syndrome, reduced ejection fraction with an improvement in ejection fraction, if you delete the drugs, the patient again develop the heart failure syndrome and depressed ejection fraction. So unless the improvement in the cardiac remodeling process and the improvement in ejection fraction, you have to maintain the 4 drugs.
Thank you, sir.
Dr. Feroz,
I think we can move on to our next lecture.
I had a little comment. As your continuation of
Yes.
all drugs.
Yes, sir.
Since the pathophysiological mechanism which involves in the heart failure is well counterbalanced by all these 4 pathways, and the pathophysiology is ongoing, so it is quite rational to continue all these 4 drugs. And it is so fortunate for the patient with heart failure that the drugs which act on angiotensin pathway, the beta blocker pathway, the neprilysin pathway, and the AGL2. These all 4 pathways do not interact with one with another. And that is why the ESC has been so smart in giving the recommendation about all these 4 drugs. So it will be wise to continue all these drugs during the recovery phase. Thank you very much.
Thank you.
May I have a short question to Gonzalez?
Dr. Nur Alam, please.
Dr. Gonzalez, just I want to draw your attention. Please have a comment regarding 2 diuretics. One is tolvaptan and another is metazolone. Usually we use tolvaptan in hyponatremic patient, especially in SIAD, syndrome of inappropriate ADS hormone, and metolazone. Have you any experience regarding these 2 drug metolazone and tolvaptan in heart failure patients as a diuretics?
No much experience, but I have some experience in our center with tolvaptan in patients with hyponatremia, for example, for improve the diuretic profile of such patients. Probably the highest experience is with tolvaptan for increasing the diuretic effect, particularly in patients with hyponatremia. This is the recommendation for using tolvaptan added to other diuretics, particularly loop diuretics.
Thank you, Dr. Ramon
Thank you.
Gonzalez. We are running very short of time. We are sorry that we cannot take any other questions about the topic.